for the introduction. Thank you, Dr. Yogesh, for the invitation to Abu Dhabi. In fact, actually, that is more practical issues in my presentation, and sure depend on the different guidelines, international guidelines. We are in Al Ain, we have around 1,200,000 population, and Tawam had 540 beds as the only referral hospital for such difficult cases. And it's rarely actually that we have one day without bleeding, GI bleeding, because we have also active oncology center. From general GI bleeding, lower GI bleeding account about 20% from all episodes from GI bleeding. And lower GI bleeding is most likely in the elderly people, which is actually challenging. And the most diagnosis that is Western, the diverticulosis and vascular diseases. That is the international guidelines from ACG guidelines, British guidelines, and European Society of Gastroenterology Association guidelines. Actually, the European ESGE is the last one, updated one. This was 2021. And I depend more on these guidelines, but this is actually what we are practicing every day. Very important, in fact, by GI bleeding, the first in the ER or in the ICU, to take actually good history. Bleeding start, hematochezia, melena, recent endoscopy, one was if he has the patient recent endoscopy, looking after vital signs, after actually rectal exam to look if there is any maroon blood in the rectum, is actually lab, basic lab. Then looking after comorbidities and medications. It's very important, in fact, to take really the history and actually the situation of the patient directly in the ER, not directly caused, as usual, the gastroenterologist to look after the patient. If the patient has GI bleeding, they have prepared everything before we have to assess the patient. That is different causes of GI bleeding, that's diverticulosis, vascular disease, polyps, iatrogenic, colitis, but this data comes from Western. I can say from our data that is actually the main causes of lower GI bleeding is angiodysplasia, anticoagulant. The second cause, ischemic colitis and radiation colitis, because we are oncology center, and for prostata and rectum and ovarian cancer, the patient had radiation therapy, and that is radiation proctitis, sorry, not colitis. It's one of the main causes of lower GI bleeding. How should patients with lower GI bleeding be stratified according to severity? In fact, what I mentioned as the assessment of the patient, but they didn't actually replace the clinical judgment of the situation of the patient after I have all of the data about hemodynamic, about lab. And that is actually the new, what's it called? That is a new, what's mentioned in ECGA for assessment of lower GI bleeding. And that is, it should be below the 8. It's simple GI bleeding or mild GI bleeding, and you can't send the patient home. And after at more than 8 in the score of lower GI bleeding, in fact, the patient needs admission also so far ICU. The first step after we evaluate the patient is the diagnosis, colonoscopy. Colonoscopy should be done in any time after the admission of the patient, and that is not only for diagnosis, also for therapeutic intention. And ECG doesn't recommend unprepared patient to undergo sigmoidoscopy or colonoscopy. Also, we have time. Not always we are under pressure from the surgeon. Please look inside and show me what's going on before to clean the patient properly. And ECGE suggests a bowel preparation using large volume, 4 to 6 liter BEG-based solution. Use of nasogastric tube. Sometimes the patient cannot tolerate too much, actually. We put NG tube or nasoduodenal, more appropriate. And over this nasoduodenal tube, we actually push 4 to 6 liter as quick lavage for the patient. And if there is necessary, we give the patient anti-emetic. What the appropriate, always the discussion in every GI department or in the hospital, when we have to do the colonoscopy, always we are under pressure, ICU, surgery, AR, do endoscopy quickly as soon as possible. But in fact, the data showing different opinion. That is actually, it's colonoscopy should be done, but anytime during admission, not in the first 24 hours. And that is this meta-analysis data, which is actually shared. A early colonoscopy doesn't improve the outcome of patients with lower gastrointestinal bleeding, and that is actually more patients hospitalized with acute lower GI bleeding don't require colonoscopy examination within 24 hours. Although 24 hours, we have something else to do. We have to clean the bowel, stabilize the patient, looking after the history. All of these factors stop, like as anticoagulant. It's just a lot of things what we have to do, not running directly with colonoscopy. And most of the patients, actually, what I observed, we do a colonoscopy, but after that is the physician can just reach the sigmoid or the descending colon, and we have to repeat the procedure. That is actually in the most of cases. Also, we need time, proper preparation, proper stabilization. And the radiology, which role of the radiology? That is, radiology actually has role when the patient unstable patient and he's not fit to undergo endoscopy. And that is the first thing what we do is this angio-CT. And after angio-CT, if we can define the lesion with angio-CT, probably the patient within 60 minutes, he has to undergo embolization or catheterization of the lesion, mostly actually diverticulosis or angiodysplasia. Surgery, if the endoscopy field and the radiology field, then it's actually the role for the surgery to look after the diagnosis and management of GI bleeding. The management, blood transfusion, restrictive versus liberal. That is the same issue in our GI bleeding. How we go with that. That is this different data, different studies showed. Actually, it is not necessary to go target above 7 grams per deciliter. That is desirable. This actually, we don't always intend to have 12 or 11 gram hemoglobin per deciliter. In patients who have healthy cardiovascular situation. In the patient have actually chronic cardiovascular diseases, then the target we are seeking or desirable target is above 10. As a 7 to 9 is the patient have no cardiac disease, and above 10, it says 11 is okay if the patient have a cardiovascular disease. Antithrombotic agents should be also always discussed with the cardiologist about the risk and benefit of anticoagulant, and if we actually need to stop this anticoagulant or not. Aspirin, if the patient, aspirin is given in two actually target, as a primary prophylaxis, like as the patient is dyslipidemic, the patient had metabolic syndrome, the most of the physician prescribing aspirin. That is the primary prophylaxis. We can stop it and we can eliminate it so far. If the patient actually have the aspirin as secondary prophylaxis after cardiac event, then we can stop actually for 5 days and we can repeat it after that. We can give aspirin after 5 days. The vitamin K antagonist, like as warfarin, the interruption of oral anticoagulant with vitamin K antagonist in patients presenting with minor, we don't need to interrupt. We can give further. If the patient have severe GI bleeding, then we stop the anticoagulant. If the patient has unstable situation, then we have to reverse the anticoagulant. Also, there is 3 scenarios. Either the patient have very low risk by the GI bleeding, then we don't need to interrupt anything. If the patient has severe, then we have to stop it. But if the patient has unstable situation, hemodynamic situation, massive bleeding, then we have to reverse with vitamin K. When we have actually to repeat that or resume the anticoagulant, say that this is after 7 days of vitamin K, if the patient has high actually risk of thrombosis, then we have actually to bridge the time with heparin, because the patient will not There's no patient die with GI bleeding. No patient. It's dying actually with multi-organ failure. Because it's with ICU, intubated, we give blood, the patient mostly dying with multi-organ failure. And if we stop the anticoagulant and the patients have high risk of thrombosis, then the patient will die from thrombosis. And we cannot replace death from the GI bleeding with the death through the thrombosis. Traditional therapy, endoscopic therapy, we have injection, we have thermal contact, bipolar, monopolar, and thermal non-contact, argon beamer, mechanical combination. Just I want to explain that is actually by monopolar and argon. Argon is actually monopolar. We have actually two kinds of current. We have monopolar current and bipolar current. We tested the monopolar current, which is actually we are using for sphincterotomy, for polypectomy. It's very deep cut. And it was actually, so begin 90, several studies came from Germany. We tested, it's caused perforation because it's very tough current. The analysis we thought that is effective but dangerous. What is the best way actually to use this current without risk? Then it was the argon beamer. The argon beamer is actually neutral gas, which is argon, carry actually the current, the monopolar current, to the tissue as a not contact coagulation. That is monopolar. That is actually the effectiveness of argon beamer. As a not, it is monopolar, but not contact, has no contact with the tissue. And that is the efficacy of argon. Mechanical hemoclips and epinephrine and BCAP or clips that different. So we have the thermal tools like as argon plasma coagulation, bipolar or heteroprobe. Bipolar we are using like as gold probe from Boston Scientific or bipolar. Bipolar is actually the probe has two wires. One wire go through the current go through one wire and come back as it doesn't penetrate the tissue. That is weak actually. Bipolar is weak current. The other actually that is mechanical over the scope, through the scope and bad ligation and epinephrine injection. I think epinephrine injection is most practical issue in the management of GI bleeding in general, but important before you decide to do anything. It is actually not ego issue. That should be, you have the availability of equipment and accessories, and that is related to the local expertise. You have expertise with which method you have more expertise to use it. It's not actually, I have to use this one and this is a new thing in the market or in the studies. It is not. Should actually, you have to do which method you can actually practicing very well. And you have the staff, as a trained staff with you for that. Angioectasis is recommended according to the ECGE, that is argon beamer. This is a good option for angiodysplasia. And you see here, the problem by angiodysplasia is the argon beamer in the right colon and duodenum. That is actually the thinnest part in GI tract. And the most perforation, it's happened in the cecum. And there is actually most likely the angiodysplasia which has bleeding. And the issue here is this best way actually to minimize, to give actually low power, 25 or 30. And the other issue, I inject adrenaline actually beneath the lesion, and it says I can elevate the lesion, and if I do actually the argon beamer, I don't have the risk of perforation. Clips, that is also sometimes in the diverticulosis, if you have good access to the lesion, and bipolar coagulation, it's weak. It is for angiodysplasia is also appropriate. The problem is probably expensive. The other is over the scope, you know, that is Ovisco, or through the scope clips. Powder, actually, that is homospray. It is not permanent method. It is actually salvage method. If you have wide actually surface of bleeding, like as a tumor or chronic ulcers, and you cannot catch any blood vessel, or you say that is probably more appropriate to spray the hemospray. But as I said, it's not chronic. It is not durable method. It is probably 1 to 2 days, and you have to think what's next. What can I do next? Delayed post-polypectomy bleeding, that is, you know, that is still 7 days sometimes. It's not directly after the perforation. Sometimes after 7 days, you have bleeding from the already resected polyp. And I like actually to use clips for such cases actually to stop the bleeding, because if you see very well the stock of the already removed polyp, you can catch it and do hemostasis. The mechanical therapy through the scope, I talk about it, a clip or endoscopic band ligation, as is expertise, location of the lesion playing as a role, and expertise of your staff, because you do that, they do the half of the job with you. Always, we requested the use of tranexamic acid in the GI bleeding. That is actually has absolutely no role. That is mostly the surgeon they use it, or the ICUs has absolutely, as there's long time actually in evidence-based medicine in gastroenterology, there is absolutely no role for tranexamic acid in the management of GI bleeding. So I go conclusion, perform high quality endoscopy for acute lower GI bleeding, search stigmata of recent hemorrhage, choose your tool, know their strength and limits, and need to further studies. And top 10 take-home messages: take the history, focus on physical examination, establish therapy, risk stratify, Auckland score, that is a score just for lower GI bleeding, Auckland score, hemodynamic resuscitation, initially crystalloid, and colonoscopy as initial diagnostic examination in most patients. Consider timing of colonoscopy, not in every price. You should have a clean bowel, otherwise you don't see the small angiodysplasia, which sometimes causes massive bleeding. Adequate colon preparation is mandatory. Care for colonoscopy to terminal ileum. Sometimes you don't see a bleeding source in the colon. You have to go to terminal ileum, and you can, if there is really in the colon and you overlooked, or the bleeding comes from above, from terminal ileum. Evaluate need for upper endoscopy at time of colonoscopy. That is in summary. We define the patient as hemodynamically unstable or hemodynamically stable with actually all the data what I mentioned before. That is actually unstable, then the patient undergo an CT angio and embolization of the lesion on surgery. That is another. If the patient is stable, we have then to transfuse here. If he is actually healthy from point of view of cardiovascular, then it says our CT is 7 grams per deciliter. If he is actually has cardiovascular disease, we should transfuse above 10 grams per deciliter. Then we have different methods to stop the bleeding, to achieve hemostasis according the equipment what you have, the availability of the equipment, the trained staff what you have, and yourself actually your preference method. The art of medicine consists of amusing the patient while nature cures the disease, according to Voltaire. So thank you very much for your attention.